Framing this in my mind in a socio-technical network, big word I learned in grad school. The sociology of it is around data governance and trust fabric, the legal infrastructure, around priority setting and resource allocation, really all the issues that Eleanor Olstrom identified in her Problem of the Commons groundbreaking work. On the technical side, we all know that means infrastructure, standards, ontologies, FHIR, HL7, all that. I want to say before I go any further, there's no shortage of conversations on the technical side, and my hat's off to you all for making sure that we also address the sociology side around governance and equity. So let's move on here. I was asked to use an example. So in this case, I actually use the organization, the Health Collaborative that I run in Cincinnati, Ohio, as the example. After a 3.5-year stint on the leadership team at ONC, I came home to my hometown and was asked to take a look at these 3 health-related nonprofit organizations, and we quickly went about merging the 3. HealthBridge was the first health information exchange in the country. Started slinging clinical data close to 20 years ago, believe it or not. The Greater Cincinnati Health Council started even earlier in the 50s. It started as a trade association of hospitals and grew over time to include essentially the entire delivery system in the tri-state region. And then most recently, an organization called the Health Collaborative was launched to bring into the fold the purchasers and civic leaders. And so we smash those together, cover a 14-county region. We have access to clinical claims, public health, and other data. We have connectivity to all major health systems, physician groups, health plans, and the larger post-acute behavioral health and public health organizations. And included in the group are essentially all the major community providers, philanthropies, local, state, federal partners. Next slide. We have about 65 FTEs, give you order of magnitude. Our vision is that by sharing data across sector, we create an infrastructure for our community that allows the right people to have the right information at the right time, specifically to prioritize the populations in our community with the greatest need. And by the way, if you look at that little map on that last slide, you'll note that we're on a tri-state, and with all the complexity that happens in many communities, it's triplicated in our market, 3 state capitals, 6 senators, all that. And one of the things that excited me about coming back to my hometown is to try to help Cincinnati be a proving ground for some of these ideas that we're talking about today and that I learned at ONC and before. All right, next slide. So I'm going to spend most of my time on developing trust and trustworthiness, and then I will show 2 very different examples of work that we've undertaken under this structure of the Health Collaborative. First of all, our board of directors is equally divided amongst providers, the purchasers and payers, and civic institutions. So on the provider side, we have the CEOs of our 5 adult systems and the CEO of Cincinnati Children's, plus 2 physician leaders. On the purchaser payer side, we have health plan leaders and purchasers large like GE Aviation and small. On the civic side, these are folks who may not be financially invested in the health sector, but they nonetheless are tasked with being concerned about our region. So it'd be the United Way CEO, the Chamber of Commerce CEO, et cetera. We have a very robust data governance process. We have a very robust privacy and data privacy and security program. For example, we're HITRUST certified, the only institution in our entire region that's HITRUST certified, including hospitals. We have some design principles. Those closest to the needs and to the work are empowered to set the agenda to the greatest possible extent. We seek to elevate the voice of people with lived experiences and co-create solutions that honor their personal experience and ideas. And Berwick's credit is infinitely divisible. So a lot of our slide decks have a lot of logos. All right, next slide. 2 examples. First, we're going to talk about the COVID-19 regional response coordination. Before I do, let me just give you a couple quick examples of work that the Health Collaborative does that you might be aware of. First of all, on the HealthBridge side, with our interoperability platform, we move about 1.5 million clinical results a month electronically across the market. We recently wrapped up the largest of the CPC Plus payment demonstrations. This was 560 practices, 12 payers, 17 different plans across Ohio and half of Kentucky. A relatively small part of our scope of work up until fairly recently was we are the ASPR designated disaster response coordinator. And, the team would do a fantastic job with tabletop exercises, ran a big mass casualty drill at the Red Stadium. But by and large, it was pretty quiet work until it wasn't. And so for the past 2 years, we've had the privilege of helping our community be coordinated throughout the pandemic. And this is how we did it. On the left, you can see the responses were tailored to the phases driven by situational awareness and surveillance around surge planning, supply chain management, testing and tracing. We stood up 1,500 testing events in low-income neighborhoods and YMCAs and community centers with our partners. Communication enforcement, school reopening, vaccination, all the things that a community would need to coordinate around pandemic response. Engage stakeholders over time and started with a shared aim and theory of change. This is how we structured ourselves on the right. This multi-agency coalition is vernacular I've learned in the past 2 years from the military. I co-chair this with the CEO of our academic medical center. Actually, Dr. Rick Lofgren just departed a month ago, but have a new chair now, co-chair. We divided the group into the delivery system, the healthcare hospital system, public health system, and congregate living. On the healthcare side, that was the C-suite of all 6 major health systems. And those guys have met at 7:30 a.m. over 300 times. The meeting is launched by a round of Name That Tune by Steve Davis, now the CEO of Cincinnati Children's. And so imagine at 7:30 in the morning before we dive into the heat of the COVID epidemic, you've got a bunch of baby boomer hospital executives arguing over who said Toto first. Incredible collaboration. This is unprecedented. Public health is all the public health commissioners, and then the congregate group represents about 400 nursing homes, jails, et cetera, treatment facilities. In all,
Craig, you're doing a great job, Craig, but you got about a minute left.
Is that right? Okay, moving on. About 400 people involved in that. The next is the community health needs assessment. We had 400 hospitals, 28 health departments, 26 counties, and a host of close to 10,000 citizens weigh in on that. Next slide. These are 2 different examples. Results from the C19 experience. On the left, unprecedented collaboration, reusable socio-technical infrastructure that Peter and I are keen on applying to other pressing public health issues. And really, to Peter's credit and his team, common language around and perspective around aims, theory of change, and the use of data. I'm reluctant to point out this slide on the right because we just calculated this yesterday, but so it's very tentative. But CDC data of the 10 leading causes of death, Greater Cincinnati performs poorly relatively to the nation on 9 of the 10 and outperformed the nation on COVID-19 deaths. I'm not sure what that means, but that's where we are. Next slide. Results from the community health needs assessment is really the touchstone now for foundations in our community, hospitals, public health departments, all are working to map their strategic plans to this common framework.
Great.
Next slide. Lessons learned. Last slide, Reed. As was alluded to before and Alonso elucidated, we have to be careful to think about the beneficiaries of data liquidity. Clearly, the incident use cases, the health sector, including health plans, and we all see and expect further optimization in that sector. The digital health economy, of course, is thriving, and we're big champions of that. The one I worry about is the general population. If we don't have forums like this to make sure that data liquidity also supports the health of the population, then we're in trouble. So thank you again for this forum. Similarly, centralization versus democratization of the data. We all can understand the pros and cons of that, and we have to think that through carefully. Lastly, is a term of art of late around health data utility. We have 5 common utilities in the country around water, natural gas, electricity, sewage, and sanitation. The question on the table is, should health data be a 6th health data utility? And that work is lots of active dialogue around that.